Hello, everyone. Today is November 15th. We've got some background noise. I'm going to start again, and I'm going to mute everyone. Thank you.
The conference has been muted.
Hello, and thanks for participating. Today is November 15th. This is a webinar on a guide to positive and borderline newborn screening results. Our presenters today are Dr. Miriam Behar and parent perspective from Angie Thompson. A little bit about Dr. Behar. Mimi is an associate professor of pediatrics in the clinical track at the University of Kentucky in Lexington, Kentucky. She completed medical school and a pediatric residency at Johns Hopkins. Mimi has also been in private practice in Oklahoma, Houston, Texas, St. Louis, Missouri, and Lansing, Michigan before joining the faculty at the University of Kentucky, where she enjoys teaching residents and medical students. Later on in the presentation, we'll also be joined by Angie Thompson, who's one of several parents who've been advising the work of this MOC4 module on parent communication. Josh, Angie, Samuel, and Abram Thompson are a busy family, and there is a photo of the family, and she said that she didn't have a chance to get the picture of the new baby in. So with that, we'll turn this over to Dr. Behar to talk about positive and borderline newborn screening results.
Great. Thanks so much, Kathy. I've really enjoyed working with this regional work group, and I'm really happy to be doing this presentation today on positive and borderline newborn screening. Next slide. So just to go over the learning objectives, first objective is to define positive and borderline newborn screening results, and also to distinguish these results from an unsatisfactory specimen. Second objective is, I think, really the main focus of this talk, is to understand how to frame the initial conversation about positive and borderline screening results. And we really want to keep in mind the needs of both the providers and the family. This is an extremely important initial conversation that you're going to be having delivering this news. And the provider may be uncomfortable delivering this news. This is not something that primary care clinicians usually do. So we want to keep both the needs of the provider and the needs of the family in mind when they receive this news for the first time that their child may have a genetic disorder. And then objective three is to identify what further steps need to be taken after getting the results. And keep in mind that we're not trying in this session to teach providers details about all these complex disorders, but we will provide you with some resources so that you can learn more about the disorders yourself, and that way you can effectively communicate with the family. Next slide. So let's move on to some definitions. So first of all, what is a positive newborn screen result? And as far as the interpretation, based on the state that is reporting the results, there might be different terminology used. So it may be reported as either positive or abnormal or out of range. And the meaning of this positive result is basically that the child is at high or at higher risk of having one of these conditions that's on the screening panel. Keep in mind that there can be some potential interferences or influences that might have occurred around the birth of the baby. Most of these factors are going to be in babies that were in the neonatal ICU, including transfusion, parental nutrition, low birth weight or prematurity, timing of the specimen, and also conditions during specimen transport. And the report sheet that you get might actually reflect these potential interferences, so the information might have been put on there when the specimen was collected. Also keep in mind, though, that it's uncommon for these factors to influence a positive result. So if you have a positive result and it says that one of these factors was present, you still need to take the results seriously and act on it, even if you're going to send a repeat specimen to confirm. And some key talking points that you always want to emphasize with the family is that this is screening. This is not diagnostic testing. So more testing does need to be done, whether the result is borderline or positive, to really definitively rule the disorder in or out. And the other point is that you're not going to just be reporting these results and sending the family on their way. You're going to be forming an action plan. You're going to be hopefully doing your homework beforehand to help you formulate this plan. You might have called someone in your state screening program to get more information, or you've probably already talked to a specialist. You'll have gathered your resources to give to the family, either in handouts or links that they can go to. And the point of this talk is to prepare you so that you can come up with a coherent plan. Next step. And then what about a borderline newborn screening result? So again, depending on the state that you're in, there might be different things reported. It could be borderline, it could be inconclusive. I'm in Kentucky, actually, they use the word equivocal, so those are some terms that you might see to reflect a borderline result. And the meaning of this is that it was basically just outside the normal range. So it's kind of between normal and abnormal, and in order to clarify whether the child actually has the disorder, you have to do further testing. Keep in mind, again, as with the previous slide, that you might see these potential interferences, but again, you're gonna repeat the result no matter what, or repeat the test. And then, again, key talking points in terms of talking with the family. You're going to emphasize that this was just outside the normal range. You need to do this further testing. So we really don't know at this point whether the child has the disorder. And I think in many cases there is a good chance that the child does not have the disorder, but you still have to get the test. Generally, on your report, the state testing program will provide recommendations as what needs to be done. And it might tell you that exactly on the report, and if not, you can always call your newborn screening program. There should be a number provided on the form so you can get more information in terms of finding out what to do. And I think I often will share my experiences with the family. For me, like the most positive equivocal or borderline result is with a slightly elevated thyroid stimulating hormone. And I normally, in this case, if it's slightly above the norm, the repeat test is going to be normal. So I will share those experiences with the family just to reassure them. I'd say we still have to get the test, but it's very unlikely that your child actually has hypothyroidism. So you can use your experience in these cases when you're talking to the family. And one other point I wanted to make is that occasionally with certain disorders, the specimen might actually be sent out by the state lab to another lab to confirm the test. We call that second-tier testing. It might be sent out to Mayo or someplace like that. So the initial report that you get might reflect this. It might say, well, everything is normal except for this one disorder that was sent out for second-tier testing. And that might delay the results on that particular disorder, and you might have to report that to the family as well. Probably most of the time it's going to turn out to be fine, but occasionally it might be actually to clarify a positive result, so that will delay your being able to report news on this disorder to the family. Next slide. And then the other report that you might get is unsatisfactory Sessom, and that's not the same as borderline. So basically the point here is that the child has really not had a screening test, so you have to repeat that specimen right away because the specimen was, they weren't able to test it because it was an invalid specimen due to collection technique or whatever. Next slide. So this is a very nice graphic. This was developed by members of our work group that helped put together this talk. And this just summarizes everything I just said in kind of a nice, easy way to see. And this will be made available to you in a PDF. It's pretty self-explanatory. What it really does is it kind of shows you the stratification of risk to the child based on the result that you get back in the report. Some things I would emphasize is under the low risk or negative or normal category, the important point here is that as clinicians, we still have to be vigilant about following the child. So even if you have a negative newborn screen for everything, you're still going to follow your clinical suspicions. If you have a child, say, that's failure to thrive and you're suspecting cystic fibrosis, you're probably going to test for that anyway, even if the newborn screen was negative. Because again, screening is not diagnostic testing. If you have a child who's falling off the growth curve, you may test them later on for hypothyroidism. So just the main point is that we're still clinicians. We still have to be vigilant even with a negative newborn screen. With the borderline results, I think the main point is that the repeat testing has to be done. You can again share with the family your experience that it probably will be fine, but you still have to do the test. And I think the main point with the last category is that if you get a positive or abnormal result, you have to jump on it right away. There has to be further testing. You're going to consult with and refer to a specialist because some of these disorders may be critical and time sensitive. Next slide. So now we're coming to the main point of this talk, which is how do you communicate this news? In some cases, this news may be devastating. And as a primary care provider, you're often or usually the first point of contact for the family, and you may be totally out of your comfort zone delivering this news. This is not something that we have to do very often. Next slide. Oh, well, the quotes aren't on there. There were some quotes. This is not the most this is not the most updated version of the slides. I remember them though. So there were some nice quotes put up there, and basically to the effect there were several quotes obtained from some families, just expressing how devastated they felt. One parent just felt like their whole world had been turned upside down, that they had this beautiful baby boy, and getting this news meant that this boy was not going to have the life that they were expecting for him. Another parent expressed just extreme guilt about that they felt like they hadn't provided everything that they needed, for this baby to be healthy. So just some pretty powerful emotions that were expressed in some of these quotes. Next slide. So this is just a nice little graphic kind of illustrating why effective communication is so important, and it compares some of the outcomes that can result from good communication versus not so good communication. So just some things to emphasize. You can kind of read what it says. As a primary care provider, you do need to have a partnership with the family, and that partnership really hinges on your communication skills. So if you can't communicate effectively, you'll lose their trust. And also, the family has to care for this child. They're the ones who, that they have a child with a potentially devastating disorder, and they're the ones that are caring for the child. And you and the specialist together have to empower them to do that. So if you can't communicate what it is that they need to do, they're not going to follow through. They may either over or underutilize medical resources just because they don't understand what it is that they need to do. And finally, there's just so much more satisfaction with the family if you're communicating with them effectively. Next slide. So there is an advisory committee on heritable disorders in newborns and children, and they've come up with this really nice tool, a communication guide that uses the acronym SCREEN. And because this type of communication is not a routine activity for the primary care provider, you can use this guide to help frame the discussion with families, to improve understanding of the results, help increase their adherence to follow-up recommendations, and generally enhance their overall experience with newborn screening. It basically provides a series of steps that you can take as a provider to communicate these results and help provide the framework for the discussion you'll have. And families have actually given feedback that using this, providers that have used this communication guide, it's really helped them cope with receiving these results and really helped them understand what steps needed to be taken and help teach them about the disorder that they'd have to deal with. Remember that for these families, getting these results can be a life-changing event, and your effective communication will really make a difference in the family's ability to cope with this potentially devastating news. Put another way, your words become part of the family story forever. Next slide. So we're going to go over this communication guide in detail. And again, it uses the letters and the word screen. So we'll just read through these. S is to share the newborn screening result and disorder-specific information with the family. C is comprehension, so you're going to assess the family's understanding and recall of what newborn screening is all about. R is for reiterate what screening is and what it is not. E is engage with the family and provide information at their desired level and pace. E is explore the family's emotions, and N is for next steps or discuss a shared plan and provide resources. Next slide. So starting with the letter S, that's to share the newborn screening result and the disorder-specific information with the family. So you're coming into the room. You have to give this news. They know nothing yet. And one of the main points I like to make with giving bad news is you have to give a warning shot. So you're going to inform the family. You're going to be discussing findings from the newborn screen, and you could start by saying something like, "There are results on your child's screen that I didn't expect." Something to give them a little bit of a warning that the news that you're about to deliver is not bad news. It's not good news. It's something bad or potentially bad. So basically, to prepare them before you actually tell them what the results are. And this is also where you're going to let the family know that you're not the expert on this condition. You're obviously going to be relying on outside help, but you are going to be with the family every step of the way in this journey, and you will help guide them through the next steps that need to be taken to clarify this and help their child. Next step. Next slide. So disorder-specific information. So how are we going to educate ourselves about the disorder so that you can educate the family? Next slide. Yeah, so this can really be the scariest part as a primary care provider because we don't know much about this disorder. We might have learned about it in medical school, but it was a long time ago. So we have a wonderful tool that we can use, and these are the ACT sheets. So these were developed by the American College of Medical Genetics and Genomics, or the ACMG, and their ACT actually stands for action. So these are disorder-specific sheets that you can get on a website that basically describe short-term actions that a health professional can follow. Some of these are going to be for you to follow as the primary care provider, but a lot of the stuff on the sheets is what the specialist is going to use also to guide their workup. So full disclosure, I had never used this before, so I went on the website, when I was preparing for this talk just to see what the website was all about, and it's quite user-friendly. You put in the link that's listed there, and across the top of the homepage, there's another link that says Medical Genetics Practice Resources. And you scroll down, and it gives you information. It gives you specific categories of disorders that are on the newborn screening panels. And then for each category, it lists the different disorders that are part of the newborn screening panels. And then for each disorder, so you click on the one that your patient was positive for, and you get two different things that give you information. There are two different PDFs. One is a PDF that basically describes the disorder and what you look for clinically in terms of symptoms and what you're going to communicate to the family. And then another PDF that has this algorithm that tells you what testing the specialist will probably do, or maybe you'll order these tests in conjunction with the specialist. But this is a very nice and easy and quick way to prepare yourself and educate yourself about the disorder before you sit down with the family. And as you see it's a little small on this slide, but you really should go on this website and try this yourself. It lists specific steps that you need to take with the family when you get the results. And one of the things that it says on there is that you consult right away with a metabolic specialist. So it really gives you the nice, step by step what steps you need to take with the family, as well as what the specialist will probably do. Next slide. So moving on in our guide, C is for comprehension. So this is where you're going to ask the family what they understand. You've just given them this news. You really want to make sure that they understand specifically what newborn screening is and what it's about. And we did have, this is the third of 3 webinars, we did have a webinar at the beginning of the series, which hopefully some of you heard, which actually goes into what newborn screening is and what it's for. But this is the kind of thing that you want to make sure the family understands. Ideally, they might have had some introduction to this, during the pregnancy, possibly communicated by their OB, but often not. So this may be the first time that they're even aware that a newborn screening test was done, and now they've got this abnormal result. So you need to really make sure they understand what the newborn screening is all about. Next slide. So here's a great resource that families can actually use, and it's a website called Baby's First Test, and the link is on the slide. And this, again, is disorder specific. The website provides some basic facts about newborn screening, is what it is and what it isn't, and has some social media features, blogging and Twitter and some videos. And it also has state-specific newborn screening program information for parents and for health professionals. It'll tell you specifically what conditions are on what state panels, and also contacts within their state program to get more information and learn about support groups. And then there is condition-specific information that is made for people without medical background, basically. So it tells about the disorder and what the treatment is. Also, there's a way to share family experiences. There's a way to do interactive blogging so that you can share your story and find out about other people's stories. So Baby's First Test, really a nice resource to share with families. Next slide. So R is for reiterate. Again, you're going to remind the family that this is screening. This is not diagnostic testing. What we've done right now is a risk assessment for the child. And so it is very important that we do timely follow-up and do further testing or refer to a specialist or whatever it is that you're going to do. Next slide. Did we skip? We skipped engage. Can you go back, Kathy? Kathy, can you hear me? Yes, there we go. So first E is for engage. So engage with the family and provide information at their desired level and pace. So again, we're going to provide the family with the disorder-specific information and go over this with them. And you may be able to get some information from your state health department. So that's, again, when you're preparing to sit down with the family, you can ask your state screening program what materials they have on this particular disorder. And if there isn't material available, you can use Baby's First Test, the website that we just talked about, to get some of that information. And make sure this really is where your sort of knowledge about health literacy comes into play. So you have to really gauge your discussion with the family based on what you feel like their level of education is and their ability to understand what you're telling them. You need to go slowly, make only one point at a time. This is where using a teach back method can be really useful. We teach this to students and residents, that you make a point and then have the family repeat it back to you, so to make sure that they've understood what you said before you go on to the next point. This is not something that can be rushed, and you're often going to be doing this in the context of a busy office day, but even if you're behind schedule, you need to make sure that you go slowly and at a pace that the family can understand. Next slide. Okay, second E is to explore the family's emotions. So you're going to explore with the family what support systems they might have in place and how they might use these as they're going through this process. Might be other family members. It might be getting information from the state screening program about other families of kids with similar disorders that they can contact. And remember, when you're going through this discussion, there can be a wide spectrum of how families will cope with this result. There can be anxiety or denial or even anger. And so you need to tailor your discussion, based on what you're hearing from the family, making sure that they can retain this information. And again, this is where a teach-back method might be very helpful. Again, I also wanted to make the point that hopefully this is going to be a discussion that you'll have in person with the family, during office hours, but you might be in a situation on a Friday afternoon where you've got a time-sensitive disorder that you have to deal with, and you may have no choice but to do this on the phone. But again, whenever possible, call them into the office and meet with them in person. Next slide. So this is just some examples of communication statements that you might use. I'm not going to read through all of these, but they're kind of divided into empathic or empathetic statements, kind of open-ended exploratory questions that you can use, and then just responses to validate what you're hearing from the family. This kind of all goes along with the concept of motivational interviewing that we teach now, in med school and during residency, where we're using our statements to guide the family or the patient to better understanding. So we'll make these also available in a document without reading through them, but just some good examples of statements that you might use as you're going through this process. Next slide. And finally, the last letter in screen is N, and that's for next steps. And this is where we're going to come up with our plan and share it with the family and give them the resources that they need. So the stop sign is just to remind you that you're not going to be going into this cold. You need to prepare in advance what you're going to say. What you're going to say to the family. Have all your ducks in a row. So you'll probably have spoken with the specialist ahead of time. You've printed out maybe some resources for the family, or you're going to guide them to baby's first test, or maybe you've even printed out some stuff from there. You will discuss with the family a shared plan that is concrete and specific and includes where and when and with whom the next appointment is, what testing needs to be done, what symptoms they need to watch for in their child, very important, because some of these disorders might be asymptomatic at first, but then the child can develop symptoms, and who can they contact if they have additional questions or concerns. And again, always after this, use a teach back or just assess the family's understanding of the information that they've been given. Again, they might be overwhelmed, and make sure that they know where to go to get more information. Oh, and one more thing, this is really where you're going to emphasize to the family that as their primary care provider, you are part of the team. So you may not be the specialist who's going to be guiding, guiding the workup and doing follow-up visits, but you are still their primary care provider. So you will still be there to do their routine checkups, their immunizations, and most likely will be their first contact point for most of the situations that come up for them. This is so reassuring for them to know that you're not just handing them off to a specialist, but that you're going to be with them every step of the way. And you are, in general, going to be much more accessible to them than the specialist is. There might be one specialist in the entire state. So next slide. So now what? Next slide. So again, going back to these act sheets, we'll be using those as a kind of a framework to outline what the next steps are with the family. So very specifically, as a primary care provider, of course, you have to determine the clinical status of the baby. So if you need to make sure that the baby is stable and doesn't need to be admitted for symptoms. You'll consult with the specialist, ideally ahead of time before you meet with the family. And then you'll initiate the diagnostic testing that needs to be done to confirm and pin down the diagnosis. And again, this might be something that you might, in conjunction with the specialist, order some of these tests yourself, or the specialist might see the baby right away and start ordering these tests. So again, you can utilize the act sheets to help guide you in this. And the example that's given here is for MCAD, which is medium chain acyl-CoA dehydrogenase deficiency. It's a fatty acid oxidation disorder. And when you go on the website, you'll scroll down for this disorder, and you'll again access two different things. You'll have PDF that basically describes the disorder and will tell you about what symptoms to watch for, and then the second PDF that you'll have is this algorithm that's shown here. It tells you exactly what tests need to be obtained and what you do if you get a certain result on the test. The slide also, there is a glossary of abbreviations. There's a lot of abbreviations on here, but this is just a partial view of the slide. So if you go down further on the slide, there's a glossary of what all the abbreviations are for the different labs. And again, the specialists might be doing these labs. They may see the baby right away, or they may say go ahead and order these tests, and then I'll see the baby after the results are back, or fairly soon. But again, with all of this, hopefully you've set this all up ahead of time so that you can tell the family specifically what's gonna happen after you meet with them. And I think that's the end of my part. Yeah, so I will turn this over to Angie Thompson, who's our parent, who's going to be giving some of her perspectives on her experiences on effective communication.
Angie, are you with us?
I am.
Hi, Angie.
Hi. Thank you so much. Yes, Amy did such a wonderful job. A lot of my points here are just emphasizing some things she said. But yes, I'm here for the parent's perspective and a quick overview of us. My firstborn son, Samuel, a day after we got him home from the hospital, we got a phone call from our primary care physician to immediately bring him back to the hospital. He was diagnosed with VLCAD, which is another fatty acid oxidation disorder. So just a few of my perspectives here, or my thoughts here. First, just the importance of taking time to consider how to give this unexpected news is so incredibly important, because parents will likely remember your words and actions forever. It really does become part of our story. And that's not meant to scare or intimidate anyone. It's just to emphasize the weight of the responsibility that you have in communicating these positive results and unexpected news. And although this is often bad news, or likely or potentially bad news, you do have the opportunity to make a positive difference for the family. In my own experience, our primary care physician actually met us at the front doors of the hospital when we arrived to bring Sam back. Brought him up to the NICU and stayed with us for like over an hour just to offer her support, and I am just eternally grateful for how she treated us that day. Sorry. Even 4 years later, I can't get through that without tearing up a little bit. But and I recognize that a lot of your schedules won't allow for something like that, because who can take out hours unexpectedly in your day and be sitting with a family in the NICU. But just any extra little step that you can offer for the family to offer your support or guidance during that time would be so incredibly appreciated. Even if it's just a follow-up phone call maybe the next day after they receive that unexpected news, it can go a really long way. And then finally, I certainly don't expect our primary care physician to be an expert in VLCAD. she, not surprisingly, did not have any previous patients with that diagnosis because of, how rare it is. So I don't expect her, 1 minute to never have seen this in her practice and then the next minute to be an expert. But what was so helpful was her willingness to learn alongside of us and offer her support whenever it was needed. And initially that looks like, having that plan on next steps. And then, going forward is just potentially helping coordinate, follow-ups with specialists or helping get labs entered in the system or whatever that may be. So, yeah, those are some of my thoughts, and I'm happy to answer any questions that anybody may have. Thank you so much for including me.
Thank you.
All right, we'll unmute everyone now. So if you do have a noisy space that you're at, if you can try to either mute yourself or ask your question and then go back onto mute. But I will unmute all the lines now.
The conference has been unmuted. The conference has been unmuted.
And we'd be happy to take questions from the audience. Any questions?
Hi, Kathy. This is Matt Edick in Michigan, and I was wondering if Mimi or someone on the line could speak to us a little bit about timeliness. Are all the positive results going to require the same timeliness, and what about the borderline results? Can you give us any additional insight on that?
I can certainly, as a primary care provider, just give what my experience is, and Sue Berry is a geneticist who's participating also. But I personally, I've never had the experience of having a positive newborn screen where it was an emergent situation, say where the baby had to be admitted right away. And I know with a lot of these disorders, say with the fatty acid oxidation disorders, if you read the ACT sheets, a lot of them are asymptomatic, and some of them never develop symptoms. So I think for a lot of them, you get this positive result, but you're not going to start seeing issues until much later. So in terms of like emergence, like you have to admit the baby right away, I think that's, at least from my perspective and what I've experienced, that usually is not the case. So you do have a little bit of time to get the follow-up testing, have the baby see the specialist. But there are some potential, I know with like congenital adrenal hyperplasia, the baby can have severe electrolyte abnormalities and get dehydrated, and those are emergent situations. But I think my experience is that those are the exception rather than the rule. But I don't know if Sue's on, if you have another answer for that.
So I'm going to augment what you say, which is that the whole point of doing newborn screening is to try and catch children who are pre-symptomatic. That
right.
being said, some of the disorders, the child will have already been symptomatic because they happen even faster than newborn screening can. So there are the Society for Inherited Metabolic Diseases and the Secretary's Committee on the Advisory Committee, the Advisory Committee on Heritable Disorders in Newborns and Children have a recommended list of what they refer to as time-critical results. These are the targets of the timeliness efforts by newborn screening programs, and the reason they're cited as timely is the potential exists for the affected child to have symptoms emerge nearly immediately. And so with that in mind, a rare event is to get a positive newborn screen. An even more rare event in some ways is to get a newborn screen for a disorder that's time sensitive. What I would say is that your Department of Health is highly likely to have a list that they regard as time sensitive and will convey that sense of urgency when they share that result with you. You mentioned some of the fatty acid oxidation disorders are a good example. Most babies with fatty acid oxidation disorders who are well fed won't run into trouble, but a baby that is fasted or that has very poor initiation of breastfeeding and who has one of these disorders might be in a challenging clinical situation. So with that in mind, it much depends on your understanding of the status of the baby. Time critical disorders in general require the primary provider or whoever is receiving that information to make an immediate assessment of the state of the well-being for the baby. If the baby's okay, you have some of that flexibility you're talking about. But they might not be okay, which is why it's time critical. Does that help?
Yeah.
Other questions? Got quite a few people on the line, so again, just speak up with other questions.
I just have a comment. I thought that was a very good explanation for the question. This is Nicole, popping in South Dakota, and I practiced for a number of years in a rural community, and we actually had a patient that had a fatty acid disorder, a metabolism disorder, present 6 hours after being discharged from their newborn stay. And they were discharged approximately, 30 hours of life, and they went home for 6 hours and came back critically ill because they had difficulties with breastfeeding that wasn't really recognized because they discharged prior to 48 hours. It was a firstborn child. All of those kinds of things happened, and the child had a glucose of 9 when it came back to the emergency room. And we didn't have, obviously, the newborn screen results back. So the spectrum is really broad, and so that's why I think this is such a great topic that everyone's discussing and participating.
Nicole, that's really an outstanding comment, and I appreciate it. This is Sue Berry again, and this also highlights the point Mimi made, which is you always have to depend in some ways on your clinical judgment, screen or not. We love screening, and we think it's super important, obviously, but their clinical impression is going to trump everything else, and your ability to respond immediately to that child's needs was obviously critical.
Yeah. Well, I think another comment, that sick newborn, that we always learn the differential infection, so that's, but you have to keep in mind that metabolic disorders, I know urea cycle defects in particular, they can present and look just like sepsis. So you have to at least have it in the back of your mind, when you're working up a baby that's critically ill, because most likely if it's presenting within the first 24 hours, you're not going to have those results back. So, so at least having it on your radar, I think, is really important.
Other questions?
So I wonder,
this
is Sue, I wonder if Angie could tell us if she had one piece of advice to share back about her personal experience when she learned about her newborn screen, that if she could go back and change it, she would. What would it be? It's a hard question.
Oh, that's a really hard question. Go back and change it.
Probably that you wouldn't get it at all, but that's not a fair answer. So.
Yeah, that'd be great.
Yeah, I wish it was the answer.
Yeah, I just can't. I mean, the way our primary care treated us, I just can't say anything bad about.
That's wonderful. I'm pleased to hear that.
And it sounds like this was one of those situations where it was you got this news on the phone. It sounds like.
Yeah.
So that's tough, because you don't have that, you don't have that face to face. But it, sounds like it was done very well, and so, which is amazing.
Yeah. I mean, I never send out Christmas cards. I just haven't gotten to that. But the one Christmas card I always send back is to our primary care, who took that day. We've moved away now, and we're not in her practice anymore. But she's just left such a beautiful mark on our lives. So
So that's a really important illustration of the concept that we're trying to make here, which is the impact that this has on families.
Right.
Thank you so much for that.
Other questions?
Hey, Kathy, this is Matt Edick in Michigan again. One other thing that came to mind to me, when we get the results back, we need to reach out to a specialist, like what's recommended on the act sheet. How do we know who the right specialist is going to be for these different potential diagnoses?
So I know, so that's information that you can access through your state screening program, basically. So they'll provide, and even actually on the I think on the ACMG website, it gives you state-specific information on available specialists that you can contact your screening program directly, and they'll give you a list of specialists basically in your region that you can contact. Is that, Sue, do you have anything to add to that?
I would say that that's generally my experience, is that in most states, the newborn screening programs have ongoing access and interaction with a group of specialists, and have identified those people who are happy to share information and to hear about newborn screened patients. In fact, they're probably sitting there waiting for you to contact them because
right.
in many cases the information about the disorder is shared with the specialist at about the same time that it's shared with the primary provider. So most of the time they're extremely ready to hear from you and very willing to support your needs. So
right.
ask the Department of Health contact that you have when you hear about the screening about who might you contact for support as a specialist.
Right, and I guess, I would assume, Sue, your pager goes off, and that you're going to get contacted, especially if it's a newborn with a time-sensitive disorder. Do you get those types of pages where you're basically being contacted by either probably by the primary care provider, and it's like, what do I do?
That's an expected part of our practice. We want and need to hear from the primary provider. We feel uncomfortable leaving people out in the cold. So if the end of the day comes and we know that there's a call out and we haven't heard from somebody, we start to get a little anxious. Yeah. Call us. So the specialist is really ready to hear from you and wants to be able to help.
Yeah. And I think all systems are different. I have the luxury. I'm at an academic medical center, and we have a nurse she actually runs the newborn screening program for the state. So, any positives go to her, kind of, I think, simultaneously also. So I have multiple people sort of on my back, that you need to do this right away. So, but that might not be the case if you're out in a more remote area. So you definitely need to know who to contact.
Well, thank you very much for excellent presentation, and appreciate the questions from the audience, as well as the dialogue and kind of what to expect during these difficult conversations with parents. And the parent perspective was so helpful to hear exactly what their thoughts were, and then also how important this communication is to the parents with a newborn. I'm going to segue over to questions I've been receiving by email from participants in the program. We have 100% have got their first audits in for their MOC4, and I've got maybe a third of the second audit results in that have been put into the run charts that are accessible. And just wondering if there's any questions from those on the line participating in terms of getting your results into the run charts, or if you're unable to do that, just being able to send them to me and then I'll enter your data. Any questions from that end of this MOC4 module?
Kathy, this is Nicole in South Dakota, and the just for clarification, the run chart is looks like an Excel spreadsheet. Is that correct?
Yeah, the run chart is the Excel spreadsheet, and then that's the data that I put into the KITA system.
So that was my. You're doing the data entry into KITA for us. We're
right.
Not doing.
I did it for everybody for their first audit just to make sure it got in there. And then some are now doing the entry on their own into the KITA system. If you're not comfortable doing that, you can still send it to me and I'll enter the data for you. And then there's a function in that KITA system that actually plots your data. So you can see from your baseline audit the improvement that you made to see what your second set of data looks like, and then after you do your second improvement project, the third set of data.
Yeah, I've done it before, so it makes sense to me. I wasn't sure the process of how to go from, I have my data collected for my second cycle, and I hadn't sent it to you yet. I was waiting to hear if we were supposed to be entering it ourselves into KITA, and then we have to have group access. So that process, I was uncertain.
Yep. So if you're unsure, just email it to me, and I'll enter it for you, and again, send you the link so that you can see what your run chart looks like. The important thing for everyone is to keep track of what your quality improvement project was between cycle, your baseline audit, your second audit, and your third audit, so that when those questions are asked, that you're able to say, here's what we did to improve with our first cycle, and then from our second to our third cycle.
Perfect.
And hopefully everybody has completed 2 cycles of audits now. Either it was August, September, or September, October. And so I do need to get your second cycle of audits in before the end of November so we can enter that in. And then hopefully you're doing your final audit this month in November. And I'll collect that data through about the second week in December if you need to get the credit on your MOC4 in 2018. We will need to have all 3 cycles of data in. I'll check that. We'll check to see that someone in your practice has been listening to the recordings either in person or looking at the archived version of them. And then there will be what's called an attestation form that's completed, and then we sign off on it, and then you're able to get the points through the American Board of Pediatrics. Any other questions? So important, send me your second set of audit data, or you can enter those yourself. If you're having any problems getting into the KITA system, just shoot me an email on that. And then usually, just so you know, Fridays are usually the day that I go back and enter data, answer questions each week, so that hopefully we can catch up with those issues and questions by the end of the week. Anything else? We want to thank our speakers, Mimi and Angie, and thank you for all the participation and for your work on this important newborn screening parent communication MOC4 module. Thank you very much and have a great week.
Thank you.
Thank you.
Thanks all.